Have you ever really stopped to think about the unsung heroes inside a horse's body?
It's amazing what goes on without us noticing.
Totally. And I'm thinking about calcium today. It's this mineral, so fundamental, right? But we often overlook just how complex its job is.
Absolutely. It's a real powerhouse. Essential for, well, everything from bone strength to nerve signals.
But what happens when there's too much, even of a good thing? That's where we get into equine hypercalcemia.
But too much calcium floating around the blood. It's a challenging condition.
So our mission, let's say, in this deep dive is to really pull back the curtain on equine calcium.
Okay.
We want to explore what makes horses so unique in how they handle it, look at the common, and maybe some surprisingly rare reasons they might get hypercalcemia.
And how we figure it out, the diagnosis part.
Exactly, how vets play detective. And then finally, unpack the strategies for managing it, all based on, the latest expert veterinary sources. Sound good.
Sounds great. Let's do it.
Okay, so let's kick things off with the basics. What is calcium's superpower in a horse?
It's got to be more than just strong bones, yeah.
Oh, absolutely. Strong bones is the obvious one, right? Bone mineralization gives that structural integrity, the power and grace, but it goes way beyond that. It's fundamental for muscle contraction. Think about every movement, from a walk to a gallop, even the heartbeat.
Wow.
Yeah, and nerve impulse transmission too, that vital communication network, plus blood clotting, enzyme processes. It's involved in so much.
So without the right balance.
The whole system can really falter.
Okay, that's a huge role. Now, here's what I find really fascinating.
Yeah.
How do horses handle calcium differently? You'd sort of think it would be universal.
That's a great question. And yeah, horses are definitely unique here. Calcium balance or homeostasis, it's this finely tuned dance.
Okay.
Primarily run by three hormones: parathyroid hormone PTH calcitriol, which is active vitamin D, and calcitonin.
So PTH kicks in when calcium is low. It tells bones to release calcium, kidneys to hang on to more, and helps make calcitriol.
And calcitriol.
That boosts absorption from the gut and also tells the kidneys to reabsorb more calcium. Calcitonin does the opposite, lowers calcium if it's too high, mainly by slowing bone breakdown.
Standard stuff so far, kind of.
Kind of. But here's the twist with horses. They are incredibly efficient at absorbing calcium from their diet, like really good at it.
Even if they don't technically need that much.
Exactly. Even when metabolic demand is low.
Mm-hmm.
And this is the critical difference, especially for vets. The horse's kidney is the main organ for getting rid of excess calcium.
Okay. Not like dogs or cats.
Nope. Healthy horses on high calcium diets, their urine is often full of calcium carbonate crystals. They just dump the extra.
So they pee it out.
Pretty much. Which means, and this is key, chronic kidney disease in horses often leads to hypercalcemia, too much calcium.
Whoa, wait. So in other animals, kidney disease might mean normal or low calcium.
Often, yes. But in horses, because the kidneys are the main exit route, if they're not working well, the calcium backs up.
That completely flips the script. What I know about my dog's kidneys doesn't apply here at all.
Precisely. It's a crucial distinction.
Okay, that unique kidney role is definitely a game changer. So now that we appreciate those differences, let's talk about when things go wrong. What are the most common culprits behind high calcium in horses?
Right. So the number one cause we usually see is chronic renal failure, CRF.
Makes sense, given what you just said about the kidneys.
Exactly. The kidneys lose their ability to filter properly, so they can't excrete that excess calcium. Even if PTH levels go up trying to compensate, the plumbing is blocked, essentially.
And what clues might point towards CRF?
Often subtle things, unfortunately. Maybe poor performance, weight loss for no clear reason, mild colic signs, changes in urination, or sometimes a history of using drugs known to be tough on kidneys, like certain NSAIDs or antibiotics.
Okay, so CRF is top of the list. What's next?
Next up, relatively common, is hypercalcemia of malignancy, or HPM. It's sometimes called pseudohyperparathyroidism.
Okay, malignancy means cancer, right?
Correct. Certain tumors, lymphosarcoma is a big one, also gastric squamous cell carcinoma, multiple myeloma, they can secrete something called parathyroid hormone-related protein, PTHRP.
PTHRP, so it acts like PTH.
It mimics it, yeah. Tricks the body, causes more bone breakdown, tells the kidneys to keep calcium. But here's the thing. Because the body thinks PTH is high due to this imposter protein.
The actual PTH level is low because of feedback.
Exactly. The horse's own parathyroid glands shut down production. So you get high calcium, high PTHRP, but low normal actual PTH.
That's a key diagnostic clue then. Any specific types of horses affected?
Well, lymphoma is often seen in younger to middle-aged horses, say 5 to 10 years old. Squamous cell carcinoma tends to be in older animals, often on non-pigmented skin. Think Appaloosas, paints, some drafts.
Got it. So kidney failure, cancer, what else?
Then there's vitamin D toxicosis, basically a vitamin D overdose.
How does that happen? Supplements?
Could be excessive supplements, yeah. Or eating rodenticides containing cholecalciferol. Or even eating certain plants.
Plants? Really?
Yeah, plants like Cestrum diurnum, Trisedum fulvescens. They contain substances that act like calcitriol, the active vitamin D.
Wow. And what does that overdose do?
It ramps up calcium and phosphorus absorption from the gut way too much and increases bone breakdown. It can lead to this nasty thing called enzootic calcinosis, where soft tissues start to calcify.
Calcify, like harden.
Yeah, mineral deposits where they shouldn't be. Clinically, you might see things like limb stiffness, painful tendons, and ligaments.
Okay, that sounds painful. And any other common causes?
Well, nutritional imbalances are usually linked to low calcium, like big head disease. But a very high calcium diet could contribute to hypercalcemia if other factors are also playing a role. It's less often the sole cause, but definitely part of the picture we look at.
Right. Always check the diet. Okay, so CRF, HPM, vitamin D toxicosis, those are the big three, maybe four. What about the rarer reasons, the zebras?
Yeah, there are definitely some less common ones. Primary hyperparathyroidism, PHPT, is actually very rare in horses.
Unlike in people or dogs, where it's more common.
Exactly. In horses, it's usually a little benign tumor, an adenoma, on the parathyroid gland, just pumping out PTH nonstop.
So in this case, the actual PTH is high.
Yes, you'd see high calcium and inappropriately high PTH. Sometimes there might even be subtle facial bone changes over time from the chronic bone remodeling. But again, super rare.
Okay. What else is on the rare list?
Granulomatous disease. Certain inflammatory conditions can cause cells to produce calcitriol, leading to high calcium, also very rare.
Right.
And then you have things that are extremely rare in horses as causes of hypercalcemia, like Addison's disease, or a specific condition in newborns called neonatal hypercalcemia and asphyxia may be linked to placental issues.
Definitely sounds like deep cuts for the diagnostic list.
For sure. You rule out the common stuff first.
Okay, so let's shift to that detective work. You suspect hypercalcemia. How do you piece it all together? What are you looking for? Not just to confirm high calcium, but to find out why.
Well, the clinical signs can be tricky because they're often vague and develop slowly.
Insidious, you mean?
Exactly. Things like drinking and urinating a lot, PUPD we call it.
Yeah.
That happens because high calcium messes with how the kidneys concentrate urine.
Okay.
Then you might see lethargy, weakness, depression, poor appetite, maybe constipation, colic signs, weight loss, just kind of generally unwell.
Anything more dramatic?
Less commonly, severe cases might show muscle tremors or even heart rhythm problems, arrhythmias. And long-term, the big worry is that soft tissue mineralization. We talked about calcium depositing in kidneys. Heart.
Nasty. Any clues on the physical exam itself?
Sometimes. Maybe swelling under the belly. We call it ventral edema. Or mouth ulcers if there's kidney disease. Or you might feel masses during a rectal exam or notice bad breath, suggesting certain cancers.
Okay, so signs can be varied. What about lab tests? You mentioned calcium.
Right. The absolute gold standard is ionized calcium, IANCA. That measures the active form, the calcium that's actually doing the work physiologically.
Not just total calcium.
Total calcium can be okay for screening, but it could be affected by other things like protein levels. Ionized is the one you trust.
But there's a catch.
Here's a catch. Sample handling is critical. Needs to be collected without air, kept cold, run quickly. pH changes can mess up the reading.
Ah. And those corrected calcium formulas.
Don't use them in horses. They're unreliable. Always confirm a high total calcium with an ionized calcium. Always.
Got it. Ionized calcium is key. What other blood markers help?
Phosphorus is important. It's often high in kidney failure, but normal or even low in primary hyperparathyroidism and hypercalcemia of malignancy.
Okay, so that helps differentiate.
Definitely. And kidney values creatinine, BUN, obviously high in CRF, but usually normal in the other main causes, unless the high calcium has started to damage the kidneys secondarily.
Right. And you mentioned PTH earlier.
Yes. Measuring PTH and that PTH-related protein, PTHRP, is crucial. It's often the game changer for diagnosis.
How so? Remind me.
Okay, so high calcium plus high PTH points strongly to primary hyperparathyroidism, the rare one.
Right. The gland itself is overactive.
High calcium plus low PTH plus high PTHRP screams hypercalcemia of malignancy.
The tumor is making the imposter protein.
Exactly. And high calcium plus low PTH plus low PTHRP suggest vitamin D toxicosis, or one of the other rarer causes.
That's a really clear distinction. Can you measure vitamin D levels too?
Yep, measuring vitamin D metabolites can help confirm vitamin D toxicosis directly.
Okay, so blood tests give a lot of clues. What about imaging?
Essential. A good physical exam, including that rectal palpation for masses.
Right.
We can use ultrasound on the neck to look directly at the parathyroid glands.
To look for those adenomas.
Right. And ultrasound or x-rays of the chest and abdomen to search for tumors or signs of malignancy. Endoscopy, like sticking a camera down into the stomach, can find gastric cancers.
And biopsies.
Sometimes needed. Bone marrow biopsy for certain cancers like multiple myeloma or biopsy of any suspicious mass gives a definitive diagnosis. In referral hospitals, they might even use nuclear scintigraphy to pinpoint an overactive parathyroid gland.
Wow, quite the toolkit. So walk me through the general flow.
Okay, first, confirm hypercalcemia, ideally with IK. Step 2, rule of the common things. Check kidney function thoroughly, review the diet, ask about any toxin exposure.
Check, check, check.
Step 3, the critical one. Measure PTH and PTHRP. That usually points you in the right direction, parathyroid malignancy or other.
Got it.
Then step 4, use targeted imaging or biopsies based on those results to nail down the exact underlying cause. It's a process of elimination and focusing the investigation.
That sounds incredibly thorough, like real detective work. Okay, so you've cracked the case, you have the diagnosis. What's the plan then? How do you help the horse, and what should owners expect?
The absolute #1 goal is to treat the underlying cause. Just lowering the calcium temporarily without fixing the root problem usually doesn't get you very far.
Makes sense. So for CRF,
For chronic renal failure, it's mostly supportive care. Lots of 5E fluids to keep them hydrated and try to flush the kidneys. Careful dietary management, low calcium, definitely no alfalfa hay, make sure they drink plenty of water, maybe phosphate binders if phosphorus is high.
so manage the failing kidneys as best you can.
Pretty much.
Oh,
And avoid anything else that could stress the kidneys.
okay. What about for HPM, the cancer-related one?
For hypercalcemia of malignancy, you have to try and treat the tumor itself, surgery, chemo, radiation, if any are feasible. But honestly, the prognosis here is often guarded to poor because it usually means the cancer is quite advanced.
Yeah, that's tough. And vitamin D toxicosis?
For vitamin D toxicosis, you first have to stop the exposure, get rid of the toxic plant, stop the supplement, whatever it is. Then supportive care, fluids, and corticosteroids can help they reduce calcium absorption and encourage excretion.
Corticosteroids like dexamethasone?
Yeah, dexamethasone or prednisolone, they can be quite helpful in vitamin detox and HPM.
And the really rare one, primary hyperparathyroidism.
For PHBT, the cure is surgically removing the overactive parathyroid gland, a parathyroidectomy. It's delicate surgery because of the location, but often curative if successful. There's also chemical ablation, injecting something to destroy the tissue as a less invasive alternative sometimes.
Okay, so treating the cause is paramount. But what if the calcium is dangerously high right now? How do you manage the symptom itself?
Good question. Acute, severe hypercalcemia needs immediate action to protect the organs, especially the kidneys. The cornerstone is aggressive IV fluid therapy with 0.9% saline.
Regular saline. Why saline?
The sodium in saline actually helps the kidneys excrete more calcium. It competes with calcium for reabsorption in the kidney tubules. So high rates of saline promote calciuresis, peeing out calcium.
Ah, clever, like flushing the system.
Exactly. Then, once the horse is well hydrated, we might add a diuretic like furosemide Lasix. It also helps push calcium out in the urine.
Okay, fluids first, then maybe diuretics. You mentioned steroids.
Right. Corticosteroids help lower calcium by decreasing absorption from the gut, reducing bone breakdown, and increasing kidney excretion. Especially good for HPM and vitamin detox. Maybe less effective for PHBT.
And any other drugs?
There are bisphosphonates, like pomidronate. They are powerful inhibitors of bone breakdown, really good for severe hypercalcemia, especially HPM. But they take a few days to really kick in.
So not for an immediate crisis, but helpful longer term.
Exactly. And of course, dietary modification, low calcium diet, plenty of water, absolutely no alfalfa or high calcium supplements.
You mentioned things to avoid too. Let's recap those.
Definitely. No high calcium feeds or legume hays. 4V fluids should not contain calcium. Avoid thiazide diuretics. They do the opposite. They make the kidneys hold on to calcium.
Bad idea.
Very bad idea. And try to avoid drugs that can harm the kidneys if there's already renal compromise, like aminoglycoside antibiotics or NSAIDs, if possible.
Got it. What are the biggest risks or complications besides the underlying disease?
The big one is that soft tissue mineralization we touched on. It's especially risky when both calcium and phosphorus are high, like in vitamin D toxicosis. If that KXP product gets too high,
The minerals precipitate out?
yeah, they can deposit in blood vessels, lungs, kidneys, heart lining, stomach.
Yeah.
It can cause irreversible organ damage.
That sounds very serious. So the prognosis really hinges on the cause, doesn't it?
Absolutely. Primary hyperparathyroidism, if you can successfully do the surgery, prognosis is good to excellent.
Okay.
Hypercalcemia of malignancy, usually guarded to poor, unfortunately, reflects the cancer.
Right.
Chronic renal failure, it's variable but generally progressive. Prognosis gets grave if the creatinine gets really high, over 10 milli-GDL perhaps.
Indicates severe kidney failure.
Yeah, and vitamin D toxicosis.
Yeah.
It can be good if caught early and the source removed. But if significant mineralization has already happened in the heart or kidneys, the prognosis turns poor.
So wrapping this up, what does this all really mean for us? It's clearly complex, this whole equine hypercalcemia world.
It really is.
Yeah.
But I think understanding it highlights just how interconnected everything is inside the horse. Small changes in mineral balance can have huge systemic effects.
And what we've talked about today hopefully gives people a better grasp of that.
Yeah, I hope so. Key takeaways for me are, remember how unique horse calcium metabolism is, especially that kidney role?
Mm-hmm.
Always push for that ionized calcium measurement for diagnosis. And realize how varied the causes and treatments are. It demands really critical thinking.
It's not just about one mineral, like you said. It's the whole horse.
Exactly. A multisystemic approach is crucial.
For me, the biggest eye-opener remains just how different horses are. You really can't just apply dog or cat knowledge, especially with the kidneys. That's huge.
It really is.
So for you listening, this deep dive hopefully shows how these seemingly tiny details of internal chemistry paint a much bigger picture of health and disease in horses. So here's a final thought. Next time you look at a horse, maybe just picture that invisible dance of calcium happening inside. Essential for life, but so finely balanced. A dance that sometimes, well, it needs some pretty careful veterinary choreography to keep everything in step. What's the one thing from this deep dive you'll remember most?